Milagros, just leave it recording.
And welcome to this symposium. We're also globally live online now, I believe. We're going to go through a few welcome slides. Next slide, please. Oh, where is it? Okay, this is a training session. Okay, very good. There is an accreditation statement and a credit designation statement. You can get up to 2.5 credits, I believe, if you're present in the room. And these are relevant disclosures by some of the presenters, including myself on top. We'll reiterate this at the time of the presentations. These are the committee members that planned this meeting. And you're already on, so you know how to get on. And the activity code in the end for the CMB is 84 giga. And it will prompt you to enter certain information into the slide. So then you can bring up the first presentation, please. It's Dr. Ochlani. And before she starts, I just want to say thank you to everybody who is here in the room. The idea of this symposium is the first symposium that we're doing up here. The first kind of mini evening symposium that we're going to do in the system at various locations. And the idea is not frontal lecture for 2 hours, but rather kind of an interactive exchange where feel free to interrupt the presenter. And we have about half and half time for presentation and discussion. So the first speaker is Dr. Ochlani, who is right here, who is one of the partners in our heart failure transplant group, and she's going to start with medical therapy in HFrEF.
Good evening, everyone. Thank you. Thank you for having me here, and thank you for this opportunity again. I'm just going to start with something that we see every day, something that we do every day, and see if there's a way for us to do it maybe slightly better. So let's start with a case. This is a patient, this is a very common scenario. I'm not sure why this is going forward on its own, but very common scenario. But this is a patient that I met with here at White Plains a few months ago. He's a 48-year-old man who came in with 3 months of declining exercise tolerance and progressive dyspnea, and then had 1 week of orthopnea, leg edema. So basically, acute decompensated heart failure, was hospitalized for this, was NYHA class 3-4 when he came into the hospital. This is his initial EKG. Doesn't show any significant ischemic changes, doesn't show any significant arrhythmias. He has sinus tach, he has some PVCs, but not very remarkable. When he presented, he was tachycardic, blood pressure was okay. I forgot to write it down there, but he was normotensive to hypertensive, not in shock. And his initial labs showed slightly elevated creatinine, mildly elevated AST/ALT, and a BNP of 1,000. He had recently had a CCTA, a coronary CTA, to look for coronary disease, which was negative. This is his echo. I am not entirely sure how I could get it to play again. Maybe click. Okay, so it plays now. So you can see this shows he has maybe a mildly dilated left ventricle, severely reduced ejection fraction on the 4-chamber view, and on the short axis, which was read as 15% maybe. So this is a gentleman with de novo heart failure. He has a non-ischemic cardiomyopathy. And the question is, what do we do next? So let's talk about the journey of this patient. But let's start with why it matters. What do we do about this, and how do we go about doing it? So why does heart failure even matter? This is a very common problem. It affects about 7 million adults in the United States. It's 700,000 new patients each year, and is basically the lifetime risk in adults over 20 years of age in the US is 1 in 5 are at risk for developing heart failure. So it's a very common problem. In addition to this being a common problem, it's a terrible problem to have. So if you look at this, is slightly older data from the 1990s, early 2000s, from a Canadian registry, but this still holds true, where you see that patients who get hospitalized with heart failure, their risk of getting rehospitalized is about 20% in a month's time, and their risk of dying is about 50% in 5 years. So that's pretty high in terms of adverse outcomes. The risk of adverse outcomes is very high. This is, again, more recent data from the mid-2000s that shows that the risk of mortality at 50% at 5 years still holds true, despite the medications we have now. So I think, we've defined the scope of the problem. We know why it's important, because it's a terrible disease to have, but can we do something about this? So over the course of the last 30, 40 years, we've evolved in our understanding of the pathophysiology of the disease state. We've moved on from thinking of this as being a contractility problem to this being a problem of dysregulated neurohormones. And here's a series of clinical trials that has basically led to development of therapy that we know makes a difference. So, this has led us to the cornerstone of medical therapy for heart failure now, which is the quadruple therapy, which is ARNIs, beta blockers, mineralocorticoid antagonists, and SGLT2 inhibitors. And each one of these medications, when added on to the previous medications, has a significant impact on the risk reduction that it gives you to reduce the risk of mortality, as well as the risk of readmissions in this patient population. And this has now been labeled as comprehensive disease-modifying medical therapy for patients with systolic heart failure. So despite this, and despite our knowledge of this and growing amount of evidence that these therapies help, there are significant gaps in the utilization of these medical therapies. This is data from several different heart failure registries over the years and clinical trials that look at baseline therapy that patients were on. And here you see that even the therapies that we've known for the longest period of time about, which is RAS inhibition and beta blockers, the utilization is only about 60 to 80%. It's much lower for MRAs and for SGLT2 inhibitors now. And there was a recent registry that showed that in the United States, the number of patients who are actually on target doses or maximum doses of these medications is less than 1% of heart failure patients. So there are significant gaps, and this is because of several different reasons. It might be cost, it might be access to physicians, access to medications, contraindications or side effects, or comorbidities such as renal dysfunction, knowledge gap with the treating team, or just inertia on the part of the patient and the part of the prescribing physician, and challenges with follow-up and care coordination. So how do we change that? How do we address this? So I think this should all start in the hospital. I think the hospitalization is a critical event in the life cycle of a heart failure patient, because one, it defines a high-risk patient. It tells you this is someone who is at high risk for getting rehospitalized, high risk for dying. So it defines that patient. Two, it also is a setting where we have control over a lot of factors that impact GDMT utilization. So you have the ability to surveil their kidney function, their electrolytes, a bunch of other factors that might impact the use. So here is what the guidelines recommend for in-hospital GDMT use. So for patients who are on guideline-directed medical therapy, who show up with a heart failure exacerbation and are not in shock, they should continue the current doses of medications that they're on. For patients who have de novo heart failure, who've never been treated and are not in shock, if they are euvolemic and stable, they should, once they, once you're trying to diurese them and make them feel better, they should be started on GDMT on all 4 pillars if possible in the hospital. And the only group of patients who you withdraw these therapies in are patients who are in shock, who are clinically deteriorating, or might have end-stage heart failure.
Okay, Yogita, let me just see if this thing works. Is this working? No. Yeah, I just want to, again, welcome everybody's in the room now. And like I said, it's going to be interactive. This is about the performance of our system. We have multiple hospitals. This is one of them. You have a fantastic team here for heart failure in-house. It's led by Farouk Jaffrey here. So I'm just going to say, show of hands, who thinks that when you're discharged from White Plains Hospital, your chance of being on all recommended GDMT is above 80%? Nobody raises their hand. Either non-participation or nobody believes that. How about above 60%? Okay, people think that might be a reasonable number. What's the real number, Jeffrey?
I think it's around 14%.
Yeah, it's around 14%. Okay, and I can tell you that is no different in Montefiore. That's why we're here. That's part of the initiative. And we can talk later about how we can improve that. But let's just to wake everybody up. And Dr. DiBiase, electrophysiology.
So
medical therapy.
why you think it's so low?
Well, we'll get to that later. I just tried to wake everybody up to see that we have work to do. So I don't want to interrupt Yogita.
So yeah, so basically, now that we've all decided we're going to start everybody on GDMT before they leave the hospital, how do we go about doing this? So there's been a slight shift in paradigm about how we initiate GDMT. So in the early days, it was always diurese the patient, start with maybe RAS inhibition, sometimes maybe beta blocker, and then wait a few weeks, and then add on a second agent, and then wait a few weeks, and then add on a third agent. But that has changed now. So now the new paradigm is you can start any or all of the agents at the same time if you think the patient will tolerate it. You could use the different clinical scenarios or the comorbidities to decide which one you add on first. So if you have someone who's hypotensive, maybe start, beta blocker, SGLT2, MRA first before you add on RAS inhibition. If you have someone who has kidney disease, you can add, before you add on MRA, you can add on beta blocker, SGLT2 inhibitors. If you have someone with bradycardia, maybe add the beta blocker last. So depending on the clinical scenario, you could, work with what to add on, but the goal really is to, and if you have someone who can tolerate all four over a span of 3 days, that it would be reasonable to try to do that for them as well. So what are some strategies that we can use for simultaneous initiation and rapid outpatient titration? So like I said, the aim really is to get everybody on all four therapies, hopefully before they leave the hospital. One of the ways to do it may just be, to be more vigilant and to, think about the comorbidities like we discussed. Another thing is setting up transition of care teams that are focused on addressing, when a patient comes into the hospital, there's several different issues that are being addressed all at the same time, but setting up these teams that are focused on trying to address this issue and will be able to follow up with the patient within a week or two from discharge. It is critical for these patients to try to see cardiologist or a heart failure cardiologist within a couple of weeks from hospital discharge. So whatever has not been started can now be started and rapidly up-titrated. And ideally, the goal is, somebody tries to see them every couple of weeks, checks their kidney function, checks their electrolytes, and is able to up-titrate their medications within a span of maybe 4 to 6 weeks.
Just to, can you turn this on? Just to add to that here, and just for the cardiologists who are here, and you probably know this, but maybe other people are online, the initiative here is that we have a heart failure clinic here now every Wednesday, and if you are unable to see the patient, they will be sent to us basically as a default. We're not assuming the patient's care, we're not taking over, we're not going to order any tests, we're just going to make sure that within a week or so of discharge, the boxes are checked so they don't fall through the cracks in the first 2 to 3 weeks after discharge. And tonight would also be a good night to, if you have questions about that, if you have commentary, criticism, this is just friends here. This is a moment to discuss it. That's why we're here. The 4 people that are here are the ones that are seeing patients here in the heart failure clinic, and each of them will speak, so they will be introduced sequentially.
Yeah, and just to talk a little bit more about this. So what evidence do we have? There's limited data about starting these medications in hospital. A lot of the literature, the clinical trials are basically done in stable chronic outpatient heart failure. There are some newer trials like the Pioneer trial, the Soloist trial that look at Impulse trial that look at starting these medications in patients. But I'm very happy to show this where we now actually have data that supports the simultaneous initiation and rapid sequence titration of these medications. This is the STRONG heart failure trial. This is a multi-center randomized controlled trial that was conducted across 14 countries, 87 sites. It wasn't based out of the US at all. It was just Europe, Asia, Africa, and South America. It had 1,087 patients, mean age of 63. Patients were randomized 1-to-1 to 2 different groups. One was usual care, where their physician decided to treat them however they would deem appropriate. And the second group was high intensity rapid sequence optimization, where they were being seen. They were started on all the medications in the hospital and up-titrated to the maximum tolerated doses within 2 weeks. And they had 4 outpatient visits over the first 2 months. And the primary endpoint for the trial was 180-day death or heart failure hospitalization. And they saw that there was a 34% relative risk reduction and 8% absolute risk reduction in the high intensity care group compared to the usual care group. And the number needed to treat with this treatment strategy was only 12. They also saw that these patients had improved patient-reported health outcomes. They had improved congestion, so fewer congestive symptoms and a lower NT-proBNP, all of which we know helps in the longer term, and then higher use of GDMP during follow-up. They also noticed that there was no excess risk of serious adverse events or fatal adverse events in the high intensity group population compared to the usual care. So this is impressive. And if you look at the table, I know it's a little hard to read here, but in every subset of these patients, classified by age, classified by gender, classified by EF, classified by their BNP levels, classified by race, they saw an overwhelming benefit in patients who were rapidly put on target doses of GDMP. So, so much about guideline-directed medical therapy. A few additional considerations for patients with de novo heart failure. So, one thing is, we always look for coronary disease, but don't always look for every other possible cause of heart failure. So that's something to consider in patients with new heart failure who have a non-ischemic cardiomyopathy. Cardiac MRI is a reasonable test to do. It helps you, with tissue characterization, give you patterns for what might be causing the cardiomyopathy. And then also gives you some sense for the scar burden, which has, as Dr. DiBiase will agree with, it has a good correlation with the risk of arrhythmic death. Think about arrhythmic cardiomyopathies. So genetic testing, that's something we do in the heart failure clinic a lot here whenever we suspect that a patient might have inherited cardiomyopathy. And then also looking for systemic diseases and inflammatory cardiomyopathies. Arrhythmias and pacing, so AFib, and very common in our patient population, but AFib, not just AFib, whether they have AFib, but also considering AFib ablation, because that might help these patients, and it might be a tachycardia-mediated cardiomyopathy, RV pacing-related cardiomyopathy, ABC-related cardiomyopathy, and whether these patients will benefit from a CRT device or not. In addition to this, we're going to talk about a few of the other things later today, which is structural therapies, but mitral clip is something that has data to support in symptomatic patients on adequately treated with GDMT, and ultimately referral for advanced therapies. If all else fails, they should be referred to advanced heart failure early before their end organs start to see damage, so that they could benefit from these therapies. Just going back to our patient, to give you a follow-up. So he was in the hospital here, received IV diuretics, GDMT was started, he was discharged on ACE, beta blocker, SGLT2 inhibitors, and then 2 weeks later, he saw his cardiologist, who added MRA at the first post-discharge visit, and he was referred to us given his young age and severely reduced EF. So he saw us at 4 weeks, we switched the ACE to RD, got a CMR to look for what might be the etiology given his age. And this was thought to be, he had some degree of scar, but this was thought to be either an inherited cardiomyopathy, a myocarditis type pattern, or maybe even alcoholic cardiomyopathy, because he had a significant history of alcohol use. We continued to up-titrate his medications, and he had a genetic test that did not show any pathogenic mutations. And at 6 months, actually, his EF improved to about 40-45%. He now is NYHA class 1 to 2, has quit drinking alcohol. So overall, this was a success story where GDMT really helped. And this patient has stayed out of the hospital for the last year or so.
Okay, thanks, Yovita. That was terrific. So if there are any questions, I know there are some questions on the chat that Snell is going to mention. But I also have a moment of brief discussion whether you perceive any specific barriers to the rapid up titration, whether that's specific to your practice pattern, or whether it's specific to the hospital, or whether it's cumbersome, things like that. I can tell you, I know it's kind of difficult to publicly discuss things that might not be perfect. That's why we showed this exemplary case. Is there anything there? Or maybe actually, Farouk, I'm going to put you on the spot a little bit, but that would be a quick comment. And then can you switch the slides to the next speaker, which is Shin? And then Yovita can just stay there, so we have the slides ready. You want to make a comment and make yourself unpopular?
So comment on rapid up titration for guideline-directed medical therapy.
Yeah, how's that going? And what does the heart failure team perceive as a potential improvement opportunity?
I think just in general terms, I would say, and I think I would probably refer this more to my cardiology colleagues for the outpatient setting, but it'd be really access to care and services. I know a lot of calendars are very full. How do we get patients in? I mean, in that particular case, he was up titrated every 2 weeks in the strong HF trial. It's very proactive. How can we be a little bit more aggressive towards this patient population? I think being able to identify accurate vital signs, it's going to be important to be able to monitor these patients. Whether you're getting them just their vital signs on those initial entries in the office versus being more proactive and maybe a remote monitoring type of platform where you'll be able to see what their trends are, especially if you're starting somebody on something and then not seeing them for
I can tell you what is, and I'm gonna, let me move on, but for us, in the other, when you look at Moses, Weiler, a lot of patients are managed on the hospitalist service, and the hospitalists, they have treat everything. So they are not as comfortable with a specific like rapid up titration in a heart failure patient. I don't know whether that's also an issue here, but certainly that's for us. I don't know if anyone from hospital medicine is here or nobody, maybe online, right? Some people signed up, I know, but that I think that's a very important interaction between us as cardiologists and hospital medicine. So what was the question on the chat?
So the question was from Dr. Paz that essentially if you have asymptomatic LV dysfunction, what is your approach to it? Do you put them on quadruple therapy or do you manage them separately? And I think we all have our own opinion on that, and we can hear yours, and I'm happy to give mine as well.
Yeah, that's a tricky question. I guess it would depend on the degree of LV dysfunction, and if they're truly asymptomatic, which can be hard to assess because patients will just decrease their levels of activity and think that that's normal for them. If you truly have an EF of 20% and you're asymptomatic, I would still treat them with pediatrics. If you have an EF of 45-50% and you're asymptomatic, I would still advocate for some therapies as much as they're able to tolerate. They would technically be NYHA class 1 then, but I would still say if you could be on an ARB and a beta blocker, maybe that's not such a bad idea to help prevent remodeling because clearly something is wrong with your ventricle. If I do have a few patients who have, some scar on MRI, EF 45-50%, claim they're totally asymptomatic. I have not done a CPET to see if they're truly symptomatic or not. I try to talk to them about, the benefits of medications that prevent fibrosis, prevent remodeling. If they're not, I have one patient like this who cannot tolerate a beta blocker because he's just like, I'm too tired. That's fine. But, if they're able to tolerate low doses of some of these meds, I think it would be beneficial. But it's a data-free zone, I think. I don't know. I think we all do what we feel like is the right thing there.
Yeah, 100% I agree that I think that especially as we've seen the benefit of these therapies, SGLT2 and Entresto added on, I myself have been more convinced to push so-called asymptomatic patients on quadruple therapy. And I think to your point of being on a minimal of ARB and beta blocker is critical. And then having a discussion with them about the risks of polypharmacy versus long-term disease progression. Certainly the asymptomatic thing then comes into the other issues of primary prophylaxis ICD. And I think that's where genetic testing and MRIs may be helpful. Yeah, 100%. I think, scar burden on MRI, definitely.
Okay, excellent. That was fantastic, Yogita. Let's move on. Julia Shin is one of the other partners in the group and also sees patients here. Yogita, I have to tell myself and Julia are the 4 people rotating through here. So Julia is going to attack the other side, HFpEF, which we see equally commonly and maybe with not as much enthusiasm as HFrEF.
So yes, I think the first question to ask is what exactly is heart failure preserved ejection fraction? So it's very generally defined as signs and symptoms of heart failure that is due to elevated filling pressures with an EF greater than or equal to 50%. The incidence of HFpEF has been rising and now accounts for more than half of heart failure cases in the US, with outcomes really being similar to HFrEF. The management of HFpEF centers around the comorbidities, less so with HFrEF, where you're really doing neurohormonal blockade. With HFpEF, it's really managing the comorbidities that probably contribute to the pathophysiology of it. The problem is that diagnosing HFpEF is not easy. So there are a lot of mimickers that cause shortness of breath that may not be due to elevated filling pressures. And to help you make the diagnosis, there's a couple scoring systems that you can use. This is the H2 HFpEF score, which focuses on comorbidities. So the 2 H's are heavy, your BMI is greater than 30, or you are on 2 anti-hypertensive medications. F is atrial fibrillation, P is pulmonary hypertension with your PA systolic pressure is greater than 35 millimeters, E is elderly, so if you're greater than 60. And then F is filling pressures as measured by Doppler echocardiography. So if you add these scores together, if you have greater than or equal to 6 points, it's highly diagnostic for having heart failure preserved ejection fraction. The more granular scoring system is this, it's from the European College of Cardiology. So it's the HFA-PEF score. And basically you go through a pre-test assessment first. Does the patient have signs and symptoms of heart failure? Then you assess for the comorbidities and risk factors, and then you do the standard echo. And then the scoring system falls under the echo and then the natriuretic peptide assessment. So you have a functional scoring system on the echo. You also look at morphologic factors on the echo, and then you look at the biomarkers. And if you have the bold, you get 2 points. If you have the minor criteria, you have 1 point. You add all of these together. If you have more than 5 points, it's highly diagnostic for heart failure preserved ejection fraction. If you have 1 or less, you do not have HFpEF. And then if you're between 2 and 4, you're kind of in the gray zone. You've got to follow this up with other testing. So functional testing in the case of uncertainty can include exercise testing. So looking at exercise echo to see if you can induce this diastolic dysfunction. Or in some situations, and we do this not infrequently, is to do invasive hemodynamics. So you put a swan in, have them exercise in the cath lab, and measure their filling pressures that way. And then the F2 is we're really looking at other etiologies. So you look for cardiac MR, you look for CT, PET, looking for inflammatory diseases, and you can go through biopsying or go through genetic testing. So you have a patient that presents with dyspnea, EDF is greater than 50%, you apply the universal definition of HFpEF or of heart failure, then you look for non-cardiac mimics. So different things can cause dyspnea, so kidney disease, liver disease. If you have chronic venous insufficiency, you can cause volume overload, and then you rule those out. You look for other mimics that cause this HFpEF physiology, but are treatable. So infiltrative cardiomyopathy, hypertrophic disease, pericardial disease, valvular disease, those things get ruled out. And then the patients you have left are those with HFpEF. And so you have to treat the underlying comorbidities in this disease. And the main ones are hypertension, diabetes, AFib, obesity, coronary disease, and renal dysfunction. So I've called together probably the most robust data we have in HFpEF patients. You have ARBs, ACE inhibitors, mineralocorticoid receptor blockers, and then you have the ARNI. And then probably the most robust data we have are for the SGLT2 inhibitors. In the past couple of years, those have been shown to not only improve quality of life, but to increase survival in HFpEF patients. So based on all of this data, the ACCHA puts together this treatment algorithm. It is actually very simple, much more simple than HFrEF. But what they say is that all patients diagnosed with HFpEF get started on SGLT2 inhibitors first. So if yellow, they have as a 2A indication, but they outline that in green because they figure with the next guideline iteration, it's going to be a class 1 indication. For all patients who have fluid retention, they get weak diuretics. And then subsets, they all fall under probably these subsets. So the rest of them should also get MRA inhibitors and ARNIs. And if you're unable to get an ARNI for whatever reason, they should get an ARB. But SGLT2 first, weak diuretics if they're volume overloaded, MRAs if they're still volume overloaded, and then you add on your ARNI. The SGLT2 inhibitors are interesting. So what are they? They inhibit the sodium glucose cotransporter receptor in the kidney, and by doing so, it increases urinary glucose and sodium excretion. So it could be as simple as that, that you increase diuresis and get the fluid off and the patient feels better. But we are finding that they actually have multiple pleiotropic effects that actually treat the comorbidities that cause HFpEF. There are a couple of adverse effects that you should know about that you probably do know about. So UTIs, they do cause a diuretic effect. So if you start an SGLT2 inhibitor and an ARNI, I actually opt to take away the loop diuretic just so they don't get over diuresis. Do not use them in type 1 diabetics, especially if they are on insulin. The pre-treatment mechanisms are vast, actually. So these medications reduce the renin-angiotensin system, they reduce oxidative stress, the sympathetic nervous system, and inflammation. And in doing so, at the heart level, they decrease cardiac preload, they decrease remodeling of the ventricle, they improve systolic and diastolic function. In the periphery, they improve endothelial function, vascular stiffness, they reduce systemic blood pressure and fluid overload. And at the kidney level you pee out more sodium and you have less fluid retention with the natriuresis that occurs. And then on the metabolic level here, you decrease your body mass, increase ketones, and decrease insulin resistance. So it really treats a variety of problems. And if you can, assume that HFpEF is caused by hypertension, diabetes, obesity, and kidney disease, well, guess what? SGLT2 inhibitors treat the hypertension and the diabetes. They make you lose weight, so it treats the obesity, and they have been found to be renal protective. So really, it just in many ways improves diastolic function in HFpEF patients by treating the comorbidities that probably cause the disease. So these are the two main trials. The EMPEROR PRESERVE looked at empagliflozin and heart failure with preserved ejection fraction. It improved survival and rehospitalizations. Same with the DELIVER trial that looked at dapagliflozin and heart failure with preserved ejection fraction. To note, the results were similar in both diabetic and non-diabetic groups. So we've also found that if you started early, you derive the most benefit. So if you look at the curves here, they splay very early. So if you have a patient who's diagnosed with HFpEF, you should start these SGLT2, preferably while they're in the hospital for their index admission, if the hospital allows for it. And then just to throw this in, this is a new player. You've probably heard about this last year. It's looking at semaglutide, which is an LGP1 inhibitor, or the Ozempic, what's the other one? The Wegovy. So this is a New England Journal article that randomized patients to Ozempic and placebo, and they found that there is an improvement in KCCQ score with a change in body weight. So, is it that it's treating the obesity and therefore the HFpEF is getting better? Again, I think this just reiterates that treating the comorbidities that go along with this disease is the most important thing. So, in conclusion, management of HFpEF really centers around the comorbidities. You have to treat the hypertension, the obesity, diabetes, AFib, sleep apnea. I did not talk about cardiomems because this is supposed to be a medical treatment trial, but PA pressure monitoring can actually benefit your patients. So I just wanted to show you, this is a patient that I co-manage with David Solars here. It's a patient who was diagnosed mid last year with heart failure, preserved ejection fraction, ended up having severe mitral regurgitation. And at some point, so if you look at the gray curve there, it looks at the mean PA pressures, and you see the mean PA pressures were quite high. And then at some point, before the curves start to drop, Dr. Latib put in a trans TMVR actually, and this patient since then really has done extremely well. So it went from 3 hospitalizations to no hospitalizations after that. And this is her download from this morning, actually. You can see that her PA pressures are actually normal. So, to conclude, SGLT2 inhibitors should be initiated in all patients with HFpEF, ideally once they are stable during hospitalization, and then you add on the MRA and the ARNI. Yeah.
Great. Yeah, that was terrific. Any questions in the room? Yeah, perfect. I'll bring you the mic so the virtual people can listen.
Thank you so much for that wonderful presentation. You did mention, if I saw correctly, that pulmonary hypertension is something that's evaluated in these patients, as you also mentioned, have multiple comorbidities. In obesity, making specific reference to sleep apnea, but how do you tease out whether the pulmonary hypertension is from intrinsic cardiac disease related to the heart itself, or is this something that's related to OSA or COPD and someone who's smoked for 50 pack years?
Yeah, so I think you're really getting to the root of the problem, and that diagnosing HFpEF is very difficult, right? So all these mimickers, they have an EF greater than 50%, yet they're dyspneic. So I agree with you that PA pressures in and of itself is not the diagnosis, but you have a sense of what the filling pressures are on echo. And if you go through that scoring system, it's actually quite sensitive and specific for this HFpEF as defined as elevated left ventricular filling pressures.
Yeah, and I also think, sleep testing is not done enough. That's for sure. And you can, if you're symptomatic, you have a positive sleep test, then I think you treat, and then by exclusion, you identify whether maybe there's something else there. Any other questions in the room?
Hi. Do you, based on the criteria to diagnose HFpEF, do you think we're over-diagnosing this in the hospitalized patients, that we're giving this diagnosis to patients that shouldn't have it? I mean, we're seeing elevated pro-BNP usually and normal EF, and I think a lot of the diagnostic criteria that you showed on the slides is not really, all of that is being taken into consideration. So with just an elevated pro-BNP is not going to make that diagnosis.
Yeah, that's a good question. I don't really know how to answer. I can imagine that a lot of patients then get diagnosed with HFpEF when they really don't. But I would argue that the therapies, since you are targeting the comorbidities that cause the symptomatology, maybe in the end, it doesn't make that much of a difference, but you may be right about that.
Yeah, let me just give you the mic in a second. We want to put a pin in that, because the gold standard to diagnose HFpEF beyond the guidelines is exercise right heart cath. And Dr. Murthy is going to address that later when we get to the other therapies. That's going to be the tiebreaker clinically, something that we don't do often enough.
Well, I was just going to say also, one of the evolutions in the HFpEF trials has been the inclusion of BNP as a criteria. And I think that is, somebody has a high BNP, it does suggest LV stretch and this physiology.
Okay, great. Let's switch over. I think Dan is next.
No, I go first.
Oh, you go first. Okay, so Luigi Di Biase also does maybe not need, we're not going to do too much introductions. Again, we're here, everybody pretty much knows each other, but Luigi is the assistant director for EP and is going to talk about his favorite topic, atrial fibrillation.
I have to say, atrial fibrillation, ablation, and heart failure is my favorite topic. Thank you, Uli. Thank you, White Plains, and all the people connected. I will share my time here with Dan, and I will give you an introduction, then we'll give you the updates that we have from the guidelines. These are the disclosure. So AFib and heart failure coexist. Almost all patients, develop heart failure, and we may not know who is the chicken, who is the eggs, but there is a strong correlation between heart failure and atrial fibrillation. And these are the data that I've been looking since I started looking at this problem, that from the heart failure trials, we know that all the time, atrial fibrillation predicts mortality in these patients. These are information that don't come from the ablationists, from us, but they come from heart failure study. And we also know that the patient that the most benefit from restoration of sinus rhythm are the one in NEA class association 1 and 2, because if you look at in this study here, the the importance of atrial fibrillation in advanced heart failure is not that much, but in more preserved NIA class association, atrial fibrillation changed the outcome of the patient. So I support and I believe sinus rhythm therapy. So sinus rhythm is an important thing to be achieved in order to improve the outcome of the patient. Now, you may want to achieve sinus rhythm with medication, good luck, but I think sinus rhythm works. And the guidelines we had before Dan will come here, surprisingly in my mind, despite all this trial here, you can see the ATAC trial, the Castle AF, the Camera, the CAMFA, the Jones, they put heart failure in class 2A as indication of atrial fibrillation ablation without any change probably from 2016 to 2020. And surprisingly, amiodarone was kept in class 1 indication. I mean, this is the most thing that I could not accept from the guidelines. We follow the guidelines, but that's what it is. In our paper in 2016, before Castle AFib, we already proved that ablation better than medication to maintain sinus rhythm, but also improved mortality, despite this was not a primary endpoint. And amiodarone is not a benign drug. There are several important complications that can be associated with the long utilization of amiodarone, but amiodarone actually increase mortality. These are heart failure trials. Here you can see class 2 and 3 again, I selected. You can see that amiodarone is as bad as placebo when compared to ICD therapy. So we know amiodarone is a bad drug. I don't think if FDA was studying amiodarone as a new drug today, I don't think amiodarone would ever be approved with current rules regimen. But as this being said, I think we don't do enough AFib ablation in heart failure. Dan will present you more trials and the new guidelines, but let's talk about this patient. He's a patient of 8-year-old from White Plains with a complicated past medical history that has already failed the cardioversion, and she's placed on amiodarone that is not working. She's symptomatic for palpitation. Her EF dropped to 29% and was 45% before. She's a scary lady because if you see the patient, she's a BMI 17. She looks a frail, 81-year-old patient. One type of patient that you see, I'm not going to do an invasive procedure, and we are perceived as aggressive, but the data are different. She's on Eliquis 2.5, Coreg, and Trestor, Jansal, and Aldactone. So probably I get the points of guiding optimized medical therapy from the heart failure specialist in the room, but I'm not sure. So these are presenting AKG here. You can see somebody may call this flutter. It could be an atrial fibrillation organized AFib by the old definition. Anyway, it's a left-sided arrhythmia. We bring the patient to the lab. I don't want to go through the details of this, but basically, after an extensive ablation, which includes, as you can see, the entire posterior wall and the pulmonary veins, we are able to achieve termination during ablation of the tachycardia here. It's important to say that heart failure patients are really not just a PVI procedure. They usually have more compromised electrograms in the left atrium. So it's a more complicated procedure, but not that much. Patient maintains sinus rhythm at 6 months follow-up with significant improvement of symptoms, and her EF also improved. And you can see amiodarone is not there any longer, but she's an optimal medical therapy for heart failure. So before Dan goes in, and he will show you more trials and more guidelines, the question I have, do you send us this patient, or we still have thinking of, oh, there are complications with ablation, we are not giving the patient to the electrophysiologist. So that's the type of discussion I would like to have before Dan goes on. Why there is still hesitation to send patient to us, or why, if I offer the ablation to the patient, I'm considered an aggressive physician. I think amiodarone has so many side effects that we should consider the risk benefit of the procedure.
Okay, great. Let me just say one thing about amiodarone. I know it's the enemy, but I'm sure it will be approved again because it's extremely effective. That doesn't mean the patients should stay on that long time. But Sneha, you wanted to say something?
Oh, no, I was just gonna ask Luigi, many of the patients we see are more New York Heart Association class 3, 3B. Would you be as aggressive with those as patients that are less sick? Or I feel like when I've said to patients, you've taken a more nuanced approach to them, the sicker patients.
So we actually have a new trial, probably, I don't know if Dan will present, we have the Castle HT that say that in patients with an end-stage heart failure, they also benefit from ablation. I mean, if the patient is advanced heart failure, but can undergo or can lay flat for a couple of hours, I think sinus rhythm therapy matters. So any effort to restore sinus rhythm, in my mind, should be taken into consideration, pending the evaluation of the patient. Not every patient is the same, but if the patient can do a procedure, I think the sinus rhythm maintenance is very important, and every effort should be placed there. What we don't like to receive is, in my big presentation on this topic, I have atrial fibrillation ablation and salvation. So what we usually have is that the heart failure doctor or the cardiologist keep the patient for years with a medication, then with another medication, then with amiodarone, allowing the progression of the atrial fibrillation to grow. And then when they can't do it any longer, then they send the patient to us. And again, AFib ablation is not salvation. The earlier we do the procedure, the better the outcome for the patient and for the operator. So the message I think we would like to give is send the patient to us earlier rather than later, before they become more persistent, before the EF goes down.
Okay, great. Just stay for a second, but you can change the slides, please. And then we move to Dan Wong. I think you can stay there for a second also. Dan Wong is the director of EP at White Plains here. Dan and I know each other also for 20 years, I think, from Columbia Times. But what I think is that, to Snehal's questions, that the standard ablations, you guys can just do it. I do think that when it comes to patients with heart failure and significantly reduced ejection fraction, as the technique has improved, as there are less side effects, as the guidelines, as we will see, are getting more aggressive, I think we should apply like the signature approach that we have, and that's why we're here all together, that the patient is potentially optimized before the procedure and then also followed after, a kind of in close collaboration. I think you'll see later our transplant results are the best in New York, number 6 in US. It's because of a big team approach, surgery, EP, heart failure. I think that sick patients where we want to consider ablations should be followed by a team, but we can talk about that later and let Dan first go his talk.
I think, again, we are proceduralist doctor, but we're also cardiologists before being EP. So we realize that before we do a procedure, we want the patient on optimal medical therapy. We want the patient with controlled hypertension, with controlled diabetes, with controlled comorbidities, with the diagnosis of sleep apnea. These are important things that come before the procedure. But that's something doesn't happen all the time because we are sometimes rushing to procedures, but the collaborative approach is the way to go.
So since we're saying we want to be open here, okay, how many patients with an EF of less than 30, when you get 100, how many of them, when you check the wedge pressure, is 25 more?
We don't check blood pressure all the time.
Okay.
Thanks, Louis. Thanks, everyone. Nice to be here. And I've been asked to speak about the coincidence of AFib and heart failure and when to ablate. So as you've heard already, the scope of the problem is huge. AFib and heart failure, they keep the same company. It's a quarter of all patients with HFrEF have AFib. Even more patients with HFpEF have AFib. 40%, other studies approach 50%. And the problem is that regardless of, we know that each worsens the other. AFib can worsen heart failure, AFib can cause heart failure can cause AFib. The problem is even when controlling for other variables in meta-analyses, AFib the signal continues to be present, that it's independently associated with increased mortality. So this in patients with heart failure. As a matter of fact, patients with AFib are 4 times more likely to die of heart failure than they are to die of stroke. So this is a big problem. And I don't want to bury the lead. I want to cut to the chase because we have brand new AHA/CC/HRS guidelines for AFib management. The first real revision since 2014, there was an update in 2019. And there's a big paradigm shift. Now we have the stages A through D in heart failure. We're invited to think about AFib as a continuum with stage 1 heart failure, and stage 1 AFib is not having AFib, but with risk factors. Stage 2, this is a concept that I've been talking about for a long time, but now it's codified, which is the concept of pre-AFib. Your patients who have frequent PACs on Holter monitoring or frequent PACs on EKG, and we've classically just been telling patients that's benign, they're just PACs. PACs and short runs of non-sustained atrial tachycardia are a very powerful predictor of AFib, and they are considered on the AFib spectrum. We don't treat them for AFib until they develop AFib, but these patients need very close monitoring because they're very likely to also, when they're not having frequent PACs or non-sustained AT, to be having AFib. Stage 3 heart failure is where we used to start talking about it. Stage 3 AFib is where we used to start talking about AFib, paroxysmal persistent, long-standing persistent, and so forth. And then finally, we have increasing data that our goals of therapy really should be to prevent patients from progressing to permanent AFib, because the greater the AFib burden, the worse the prognosis in terms of death and stroke and heart failure. So here's the take-home message right away. This is a real paradigm shift. Sinus rhythm has really jumped to class 1 indications for 2 major subsets of patients with AFib. One with patients with new diagnosis of HFrEF and AFib, where there should be a strong suspicion for AFib-induced cardiomyopathy. Previously, it was just described as tachycardia-induced cardiomyopathy, but I'll show you in a minute why we really should think of it as AFib-induced cardiomyopathy, independent of whether they have rapid ventricular response or not. And so for these patients, an early and aggressive approach to AF rhythm control is recommended. The other one, which is a lot of our patients, which is in patients with AFib and HFrEF, which is almost 40% of patients with HFrEF have AFib, who are on guideline-directed medical therapy, where there's a reasonable expectation that it's going to help catheter ablation, improve symptoms, cardiovascular outcomes, quality of life, and ejection fraction. So this is class 1, and this is, again, it's a big paradigm shift. We need to stop thinking about thinking about AFib as in the only way that AFib can hurt a patient with heart failure is if their rates are not well controlled. That outside of the mechanism of tachycardia-induced cardiomyopathy, as long as your patient's rates are well controlled, they're okay. Here's a nice review article by Barry Bordelog and colleagues, which shows pressure volume loops, not for the ventricle, but for the atrium, and how, with this vicious cycle that happens with atrial fibrosis and remodeling and AFib, they develop stiffening of the atrium, a steepening of the left atrial pressure volume relationship. And then when they develop AFib, they have incomplete atrial emptying, which then leads to an upward shift in the pressure volume relationship, which then independently increases left atrial pressure, wedge pressure, and can lead to heart failure. You also lose your atrial kick. Okay, so the top one, left atrial dilatation, decreased compliance, changes in the pressure volume relationship. The second one, fibrosis and decreased compliance. But don't forget about atrial fibrillation leading to functional microregurgitation. We all know about cardiomyopathy in the ventricle leading to functional microregurgitation, but there's a growing recognition of left atrial enlargement itself and caused by AFib as a powerful contributor not only to functional MR, but functional TR. Also, the irregular cycle lengths from AFib can directly cause cardiomyopathy, and the total left atrial enlargement can cause this phenomenon of pericardial restraint, which is stretching of the pericardium, and the pericardium itself has a pressure volume relationship that can then decrease cardiac output, increase wedge pressure, and lead to heart failure. So there's a lot more data now supporting some mechanisms independent of tachycardia. I like this slide because it reminds me why as electrophysiologists we're so interested in heart failure. Of all of the different arrhythmias that can contribute to heart failure, our two tools that we really focus on have been CRT and catheter ablation. This is aside from pacemakers and defibrillators. And again, tachymyopathy we know about, but this concept of irregulopathy is gaining traction because we know that PVCs can cause cardiomyopathy, not just from dysynchrony, but from these post-extrasystolic potentiation. And that really increased contractility is actually probably deleterious and leads to abnormal calcium handling, abnormal gene expression in terms of the components of the sarcoplasmic reticulum. So just the irregular rate can lead to this irregulopathy concept that causes heart failure. We know about AV uncoupling, loss of AV of atrial contribution to the stroke volume, which can be up to 30% in patients and then they can have a 30% reduction in their stroke volume right off the top. And then, of course, we know about dysynchrony cardiomyopathy. So this is a nice slide for us to realize that we really should be thinking about AFib-induced cardiomyopathy and not just tachycardia-induced cardiomyopathy. There's a lot of data. I just want to show you one representative randomized trial from each. This was one of the landmark trials that led to the current guidelines, which took patients with persistent AFib and heart failure and who met indications for primary prevention ICDs. So all these patients had ICDs, and they were randomized to usual therapy, which is just regular rate control, the guideline-directed resting rates of in the 80s to 100, and the catheter ablation. And there was significant reduction in the primary endpoint of death or hospitalization. And there was a 47% reduction at 5 years in mortality from any cause in the ablation group. Okay, and this was, and it turns out that one of the strongest predictors of decreased mortality and hospitalization was the ablation effective or not? So the ones that had significant reduction in AFib burden. But what about the AFFIRM trial? The AFFIRM trial has been guiding the way that we treat patients for the past 25 years. No significant difference, maybe a trend towards harm in antiarrhythmic drug therapy versus rate control therapy. It came out when I was a medical student, and so now we have 2 decades of patients who some of them have been in AFib for about 2 decades or longer. Well, I think the East AFNet 4 trial as a more modern version of the AFFIRM trial, where this time the AFFIRM trial was essentially a trial of amiodarone and sotalol, which showed that these patients had a lot of antiarrhythmic drug side effects, proarrhythmia, toxicity, and death. What if you tried a more modern approach where in the East AFNet 4 trial, patients who were randomized to sinus rhythm were allowed to have catheter ablation? They were allowed to use more modern, less toxic drugs like dronedarone. There was more use of drugs like flecainide or propafenone. This wasn't just heart failure patients. This was actually a much healthier group that includes some paroxysmal AFib patients and patients without heart failure. And there was a 20% reduction, relative risk reduction, in the primary endpoint of cardiovascular causes of death, stroke, or hospitalization. So this is a more modern version that really has demonstrated that better, more effective, less toxic forms of rhythm control do result in significant improvement, even in a relatively healthy population. This is what we see in the EP lab. These are two patients side by side who are having their AFib ablations. This is an electroanatomic map of the left atrium. On the upper left there, that's the bottom right is the mitral valve. And here the left upper and lower right pulmonary veins. Here's the posterior wall. Purple is normal. Purple is normal voltage. The patient on the left has only been in AFib for 6 months, and the patient on the right has been in AFib for 5 years. So in red, and anything that's not purple shows fibrosis is a surrogate for fibrosis. And it turns out these electroanatomic maps, these voltage maps that we made, actually correlate well with cardiac MRI, looking at late gadolinium enhancement. And so you can imagine why the patient on the left will do better with pulmonary vein isolation alone. And on the patient on the right, you can see that the substrate is sort of the horse has left the barn. Pulmonary vein isolation will help, but this patient probably needs much more than pulmonary vein isolation. You know, Alan, you mentioned, you know, how can you tell if the patient's, you know, with HFpEF, how can you tell if it's you know, if it's pre-capillary or post-capillary? Short of doing a right heart cath, it's possible we're overdiagnosing HFpEF. Well, every time we do an AFib ablation, we have a golden opportunity to directly measure the left atrial pressure. And I think it's something that we should take advantage of. And I actually find that, you know, we measure the mean left atrial pressure, we measure the V wave. And I think HFpEF is what's the definition of heart failure to an electrophysiologist? It's the inability to keep left atrial pressure low. You know, if you can't maintain normal filling pressure, so you'd be surprised how many patients are sent to us for AF ablation who have normal EF, and their symptoms include dyspnea, and we attribute to the AF. And then I do the transeptal puncture, and their mean left atrial pressure is 24. That patient has HFpEF. And so it's a golden opportunity to really do, you know, how often do you get to directly measure someone's left atrial pressure? We can do it every time. Okay, so it turns out the East AFNet trial, the other take-home message was that early rhythm control matters. All of the patients in this trial were in AFib for less than 12 months. So early intervention matters. Here's a graphic, here's a video description of early versus late. Okay, so you might say, yeah, but AFib ablation frequently doesn't work. Look at one of our best randomized clinical trials, the STAR-AF2 trial for persistent AFib. It turns out whatever strategy was employed, pulmonary vein isolation alone, pulmonary vein isolation plus CAFE or complex fractionated atrial electrogram ablation, pulmonary vein isolation plus linear lesion sets, which is something that I believe in very heavily. They weren't able to show any improvement. And look, at the end of the study period, only about 50% of the patients were in sinus rhythm. So why are we pushing this to class 1 for a procedure that, even though it's come a long way, only 50% of patients are still in sinus rhythm at the end of the trial? Same with the Castle AF trial, which showed that 47% relative risk reduction in mortality. Only 60% of those patients were still in sinus rhythm by the end of the trial. So how do we reconcile this? Well, it turns out in EP clinical trials, if a patient has 31 seconds of AFib, 3 months after the ablation, they're adjudicated as a failure, treatment failure. So it's important to have very rigorous clinical trials to have universally agreed upon endpoints of what we decide is successful or not successful. But practically speaking, if you look at the much more important metric, which is AFib burden, in the STAR-AF trial and baseline, they had 80 to 100% AFib burden. These were patients with persistent AFib. And yes, this was a negative trial because we couldn't figure out which is the best strategy to ablate these patients. But regardless of what the strategy is, these patients had an average reduction in their AFib burden to 10%. So not AFib free, but it turns out in heart failure, we should think of AFib more as total area under the curve. The less time they spend in AFib, the better. And then the worst part of the curve to get to is permanent AFib. So AFib burden should, in many ways, be a more important metric. Now, that's different from our highly functional, highly symptomatic patients with paroxysmal AFib. Even 1% AFib burden is too much for them. But when it comes to patients who say, well, I'm asymptomatic, I don't feel palpitations, it doesn't matter. The AFib is still a terrible predictor of mortality. And so our goal is we want 0% AFib burden. But if we can't get there, even a reduction is important. Okay, so the group on the left are the ones who are the best candidates for early referral, not a lot of scar or fibrosis. If we believe that if we have a temporal correlation where they had a normal EF and then they developed EF, AFib and their EF dropped, those are more likely to benefit from sinus rhythm. Now, it just so happens most heart failure patients, more and more of them are the ones on the right. Because all it takes is 12 months of your AFib diagnosis, and now immediately you're in the next worst category of AFibs, of stage 3 AFib, long-standing persistent AFib. So we're getting much better and much more experienced at ablating long-standing persistent AFib. And most of our patients nowadays look more like the ones on the right than the left. And it doesn't mean that we don't tackle these patients and still expect a reasonably good outcome. Okay, but when the patient's left atrium is already 6.5 centimeters, or I look on the echo and their left atrium is bigger than the left ventricle, a lot of times sometimes we say we need to think about other options. Okay, so, even to someone like me who spends all this time, almost, I think sometimes thinking about AFib and how not to have AFib and ablating AFib, this is a challenge, that the 40% of patients with HFrEF really should be considered, that the idea that we should be thinking about sinus rhythm as a therapeutic target, the way we already automatically think about complete left bundle branch block in patients. We would never leave that unresynchronized. Yet we're doing that with our patients with sinus rhythm and normal heart rates or well-controlled heart rates. Okay, so it's a paradigm shift. AFib burden and stage matter. Ablation as a way to reduce AFib burden, even if you can't get it to zero, which is the goal. Ablation as a way to prevent a progression of AFib from paroxysmal to persistent, or from persistent to permanent. Earlier is better. And many of our patients have long-standing persistent AFib at this point. So, but very practically speaking, can we really put our patients with an EF of 15% through a several-hour procedure? In this country, the standard of care continues to be general anesthesia. Can they even handle the induction of general anesthesia? The 1 to 2 liters of fluid that with current techniques typically, they can be net positive at the end of the case. The procedure time and the recovery time. So, another thing I spend a lot of my time thinking about is the risk-benefit ratio. Until, Luigi and his, team of world-class clinical trialists, really, continue to and give us the next big thing in our field, what can we do? What do we focus on here in our lab? Well, how can we make the ablation safely, not an 8-hour procedure, not a 6-hour procedure, but a 1 to 2 hour procedure? If our patients can tolerate it, can we move toward doing ablations without general anesthesia? Okay, can we send a patient home the same day? These little things that don't make it into clinical trials actually matter a lot. What if there were an ablation modality that didn't require giving a patient a liter or more of fluid and mitigated some of our grave concerns about rare but serious risks like esophageal fistula? So, we're in an evolving field, and we may actually have some answers for you this year. Thanks very much.
And then that was outstanding, Luigi. Also, I have actually a number of questions. Is there anything in that chat that says yes or no? No. So I like the fact that you measure the LA pressure. Luigi and I actually have been talking recently about doing this systematically for research purposes. But what neither of you said, because we might have a general audience on the global web, whatever it's called, just can you just say what are current rates of major adverse events of an ablation? Perforation, you name it. What are the issues? And my understanding is that with the pulse field ablation, if that's correct, that has become much less. Maybe just give a little bit didactic on complication rates.
3 to 5% is, I would say, the range in clinical trials quoted of major complications. Now that's a lot. That's very high, 3 to 5% rate of major complications. But it turns out the overwhelming majority of those are groin vascular complications, and that counts as a major complication. But we're not talking about the other dreaded complications, which are atrial esophageal fistula, which can be anywhere from 1 in 500 to 1 in 10,000, depending on which paper you read. Phrenic nerve palsy, pulmonary vein stenosis, cardiac tamponade, need for emergency open heart surgery, stroke, and myocardial infarction. Those are the dreaded ones, and those are closer. I wouldn't say exactly, but those are closer in the same category of risk as if the patient were needed as PCI.
Yeah.
Okay. So, so the groin vascular complications, that's very easily addressable with modern techniques that we use, such as, for example, even just in the past 5 years, switching to ultrasound guidance for access.
Yeah, maybe that's a good take-home message for the audience, that complications of modern AFib ablation elective is somewhat comparable to modern elective PCI, and given the benefits of ablation, it should be more often considered. Other question I have for both of you is practical. Okay, now that if you go back to that guideline slide with the class 1 recommendation, so a patient comes in with HFrEF and has atrial fibrillation. That one. So it's now a class 1 recommendation, an early aggressive approach. What does that practically mean? It does probably not mean an EP consult right away, maybe. Should I cardiovert this patient during their first admission? Should we first treat them with GDMT, anticoagulate them, and if they're still in AFib, bring them back for cardioversion? What's your take on this?
My personal approach is we have millions of trials proving that AFib ablation works better than medication. We didn't have trial proving improving mortality, but restoration of sinus rhythm, there's a randomized trial, there's agreement among everybody, including heart failure. So my point is why you want to start with a more ineffective therapy to restore sinus rhythm rather than starting with the most effective therapy to restore sinus rhythm. So my personal approach and practical approach is I would offer immediately an ablation, and after the failure of the ablation, I would give a chance to the medication to coordinate with the procedure. The complication of the procedure have turned down. We might have new energy source that may limit even the amount of fluid that we deliver to the patient. So my personal approach is to start with the ablation. Of course, if it is the first ever episode of atrial fibrillation, even to prove to the patient that in sinus rhythm he might feel better, doing a cardioversion and putting the patient in sinus rhythm for some time, I use it as a bridge to the ablation. Even if I plan an ablation, I say, let's start with the cardioversion, then we schedule the ablation after. And I think done that similarly, but I'm pretty sure.
So ablation in the emergency room, if that can't be done, cardioversion while in hospital?
Cardioversion while in hospital, yeah.
Okay, Dan?
Yeah, I mean, I think it's, I tell patients, it's about shared decision-making. One way or the other, what we don't want to see, and I see this too often, is someone developed heart failure and AFib, and then the AFib they weren't even given, everyone deserves at least one chance of sinus rhythm, and now 5 years later, they're still in AFib, you see. And so I say, if you want to have a cardioversion, I say low risk, low reward, but it might work, it might not. And I say, if you want to have an ablation, slightly higher risk, much higher reward. And so it's risk benefit.
Okay, so the cardiologist in the room, anybody has, you are the ones that see, anybody has an opinion? Patient comes in, EF is 30%. Hold on, they can't hear you. If you gotta like.
I have a 52-year-old who came in last night with AFib.
Yeah, take the mic. Otherwise, they can't hear you on the internet.
I have a 52-year-old who came in last night with AFib. He got 60 milligrams of diltiazem 3 times a day, was ruled out and sent home. You talk about immediate cardioversion, and he's going to get in. They told him to follow with the cardiologist, and hopefully he'll get in sometime in the near future.
I mean, I think you did a cardioversion by giving diltiazem because he reverted to sinus. I mean, cardioversion doesn't have to be electrical; it can be chemical. It's a cardioversion. Cardioversion is electrical, chemical. If you restore sinus rhythm somehow to this patient, it doesn't have to be electrical.
Let's go to the mic for the questions, just so that.
I mean, we're talking about AFib and heart failure. Not everyone with a brand new diagnosis of AFib needs to be cardioverted. I mean, there's I think you're talking about the AFib ED pathway, which is trying to prevent patients from waiting, from clogging up lymphocytes.
But shouldn't you extrapolate that to that?
Yeah, but that's the amount of AFib visits that new AFib in the ER. I mean, Farouk is right here. It's probably some shockingly high percentage of reasons for ER visits. Not all new AFib needs to be admitted, you see.
Right.
And if the patient can get prompt follow-up, start on an anticoagulation right away if appropriate. Can it happen a week later? Can it happen a month later? Sure.
So new AFib doesn't need to be cardioverted.
Or admitted if they're stable, and otherwise, and it's new to us. Oftentimes, when I look into the patient's Apple Watch records, you find out they've actually been in AFib for much longer.
But what is new when Dan went through is early intervention, like AFib progress. We have no time to talk about. There are 2 randomized trials that have proven that if you treat paroxysmal atrial fibrillation with ablation or with medication, the number of patients that progress to a more persistent or more higher burden of atrial fibrillation with ablation is lower than with medication. So, I mean, an analogy I use with my patient is that this is not cancer, it's a more benign condition, but everybody knows that if you have breast cancer and you have a lump in the breast, the earlier you remove that lump, the better is the outcome. Ablation of atrial fibrillation is the same. The earlier we intervene, the better is the outcome. If you let the patient go, then goes home in sinus, then 6 months later another admission, then you allow the progression of the disease to a more of the image on the right that Dan showed you, and then it's harder for the ablation to work. So the earlier the intervention, the better the outcome.
Okay, terrific. That was great. I learned actually a lot. I didn't know about the new guidelines and the class 1 recommendation, but I think the take-home message maybe for this part, which was kind of the standard of care, is that heart failure and atrial fibrillation are, very much related, and newer techniques allow safer ablations, and the evidence is clear that early intervention reduces hospitalization and possibly improves mortality in the long run, promotes reverse remodeling, what we're looking for. So this was kind of the, I'm a little bit concerned actually from a length of stay perspective if everything is done on the same stay, so that's just one input there. But we're going to move on 2 more presentations where we're going to show you some new things that assume that, assume that you have already applied all therapies properly, and the patient is still symptomatic. I will give a brief talk on a trial that we are actually leading globally. There, we've already enrolled several patients, and Azim Latif, who is here, basically my co-presenter for anything that I just talk about, but he does. We can go into detail. This is a study for HFrEF, and after me, Sandhya Murthy will show a study on HFpEF in essentially treatment refractory patients. Thing here. So we talked a little bit about remodeling. We don't have a lot of time to go into detail. Let me just say that any trial in heart failure with any intervention, if you induce reverse remodeling, heart failure hospitalizations will go down, survival will improve. We have here a brief cartoon of Laplace's law that has been tested by surgical trials many times to no avail. But the idea is that if you have a smaller LV radius, you will have less wall stress, and less wall stress might induce reverse remodeling. And I'm going to show you some early data and invite you to send your patients for a clinical trial where we're testing this concept now in 80 centers worldwide in patients. As a backdrop, what you can see here, we're not going to talk about mitral valve disease and mitral clipping. You well know that there's a dramatic mortality benefit in the right patients from mitral clip. What you may not be as aware is on the left side that after 5 years in that study, while there's a significant mortality benefit, the outcomes are still abysmal, with 75% mortality in the treatment group. It's worse in the medical group, but it's still very bad. And on the right, you will see that in red, the patients who are not treated with a clip continue to enlarge their ventricle, continue to remodel, it increases. And of note, the patients with the clip, even though do better, they also continue to remodel. Less so, but they still remodel. So the question is there something where we can address this remodeling process and induce reverse remodeling? And in comes the, can you click this for me so it plays? Click this now, and then click the other one when I say now. So here's the approach. This is the femoral approach. You go inside the left ventricle. You come inside the left ventricle, and now play the other picture also, please. Very good, thank you. And what's going to happen now, and Azim has done this many times, so he can answer any questions that come up. There's a catheter put behind the papillary muscles around the left ventricular wall, away from the conduction system. A guide wire is placed, and then a series of anchors and sliders is placed in the myocardium, and then the heart is cinched down and made smaller. So mechanical, percutaneous, reverse remodeling. On the right side, you actually see a fluoro of one of the patients. You can see these little sliders that are there, and if you watch this, they're coming together right now because the device is being cinched. I can't see this well from up here. This is now like a little bit more than a semicircle sitting 2 centimeters below the mitral valve. This is not a mitral annuloplasty. This is a ventriculoplasty. This is the technology. We're doing this. We're actively enrolling. Let me move to the next picture here. There you go. You can see here in purple where this line of anchors and sliders was before it was cinched together with a cinch line, and after you reduce the radius by almost a centimeter at that level. Procedure time in the first 50 patients, I'll show you in a second, was about 2 hours, and about 13 anchors are placed. Left upper corner, you see this device in an animal right after it was put in. You try this in sheep first, and then the sheep is sacrificed, and here is the device. On the right, you see a device. This was actually a clinical case, one of the very early cases, a compassionate case where the patient died. And this is 10 days later. You can see that the device is already being endothelialized. I can't move this cursor. And on the right lower corner is a patient who got a transplant after 3 months, and you can see that the device is fully integrated into the wall of the myocardium. Here's a cross-sectional cut through the cinch line of this device, and it's really a suture that is fully being integrated. Observation that is made in this anecdotal case on the right, all these patients get a CAT scan with contrast at the outset, and a year later, you can see on the right here in purple was the original CAT scan. This is a 3D reconstruction, and in blue is the CAT scan a year later. And what you see is that and here is where the cinch line is, but in this case, the entire ventricle has gotten smaller. Details of this, the first 50 patients we publish this year in the Journal of Cardiac Failure. If you're into it, you can read this. I'm only showing this because at the end of the day, people talk a lot about stuff, and the best evidence that we can rely on is published and peer-reviewed evidence, and this is in the Journal of Cardiac Failure. I'm going to briefly show you the data. This is a convenience sample from 4 studies. This device was tested in patients with mitral regurgitation and without. For strategic reasons, the company left the mitral field and went for the no mitral regurgitation patients because there's really nothing else for them. 50 patients that had an EF of 20 to 40% and did not have more than 2+ MR while they're on optimal medical therapy. They were fitted with this, and safety and efficacy were analyzed over the next 12 months. This is kind of a standard heart failure population, slightly younger, 56. 75% were non-ischemic. They had a relatively low rate of ICD because many patients are in Europe. They're not as ICD aggressive as the US guidelines are. All these patients had class 2 to 3 heart failure. Ejection fraction was low, 29%. The left ventricular end-diastolic volume, though, was big, 200 cc's, and an LVEDD, if that's more familiar, of 6.6 centimeters. So big hearts, medium ejection fraction on drug, no significant MR. What about safety? In these first 51 patients, there were 3 vascular complications. We discussed this happens also in EP. This is the 20 French arterial sheath. This is a big sheath. They get a TAVR CAT scan before to make sure it fits. But all these complications resolved without sequelae. And there was one patient you might worry about going onto the LV, placing 15 anchors, placing 15 sliders, 30 pieces of something, put them together and leave, whether they can embolize and break off. To date, about 150 patients have received that. You can do the math. That's about 4,500 pieces. And so far, no embolization has been reported with this device. So it's quite safe. And here are the results. Now, you have to take this with a grain of salt. This is an open label study. The patient knows what they're getting. The doctor feels great about having placed this and asked them, are you feeling much better now? Kansas City Cardiomyopathy Questionnaire, an increase of about 15, 20 points is meaningful. They have that. 6-minute walk, as you probably know, 50 meters is quite good, is a meaningful result. Again, this is subject to coaching. Yeah, now you can walk more, try a little bit harder in the 6 minutes. But here's the important data from the study. This shows you the reduction in left ventricular end-diastolic volume. And what you can see over 12 months is a initial physical reverse remodeling that's relatively small, from average 200 to 190. But then without further manipulation of this device, without further mechanical manipulation, we observed reverse remodeling. And we have to think that this is now a physical induction of biological reverse remodeling. This is 50 patients. These results were very encouraging. Importantly, the echo was read by a blinded reader. They may be able to see the device, which in the registry is irrelevant because they know they have it, but for a randomized trial, it's a different story. They may be able to see the device, but they don't know when the study was done. So this data was felt to be very compelling, and the ejection fraction goes up slightly. New York Heart Association class, again, you have to take this with a grain of salt. This is subjective. This is in a registry, improves. Hospitalizations are less, but you see this very often early on in studies because now the patient is under the magnifying glass by the heart failure specialist who, under no circumstance, admit the patient again. This is cute, but it doesn't really mean much. The reverse remodeling by the blinded reader is where the money is. So in summary, for these 50 patients, what we have seen is a significant and progressive reverse remodeling. They improve their quality of life. They improve 6-minute walk. And most importantly, the ejection fraction only slightly improves, but the LVEDV reduced from 200 to 160 cc's. As a result, there is now a large randomized study. There are now about 60 US centers and about 15 to 20 European centers. I'm one of 2 global PIs. The other one is Mark Riesman, who's an interventional cardiologist. Azim is here, he's the chairman of the steering committee for the trial. This is ongoing. We're looking to enroll 400 patients. And again, this study is run by heart failure doctors. So you can't just come in and get something right away. They have to be on state-of-the-art 2024 medical therapy for HFrEF. Otherwise, there's an approval committee for this, will not let them go through. If they have left bundle, they must essentially have a CRT device. And if they deserve an ICD, they should have that. Only then, if they remain with class 2 to 3 symptoms that are further validated by a 6-minute walk of less than 450 meters, can they be enrolled in the study? At this point, this is a randomized study that's ongoing. We have 85 sites right now. We have, as of last week, 113 patients randomized. We have done, I think, 5 or 6 cases total at MonteHeart. So if this is interesting to you, if you have patients that are interested, I showed you the initial vascular complications in the 50 patients, the 20 franchisees. There is no vascular complications in the first 51 randomized patients in this trial. So we feel this is safe, and based on the remodeling data, reverse remodeling, I should say, this is something that, and again, this is where we come in as MonteHeart Health System. In our system, patients who are treated optimally should be made aware of investigational options. So I'll leave it there. If you have any questions about this, I can take them right now. Maybe Azim, I would ask you a question. Use as a routine of this show. Going in there, placing 16 anchors, going behind the papillary muscles, how, from a structural interventionist perspective, is this a difficult procedure? Is this an easy procedure? Where do you place this?
Yeah, I think that's a great question. I mean, I always like to give it as a comparison to something else we do. For example, a mitral clip procedure, which nowadays a mitral clip procedure probably takes me about 40 minutes to do in most cases because I have great imaging. This procedure probably takes about 2 hours to do. The hardest part is actually just trying to make sure you're outside all the chordae, because you got to go into the ventricle and you have to navigate behind all the chordae and pulmonary muscles. So you right against the ventricle. That's the hardest part. Once you're in there, you put this catheter in, and then it just becomes a little bit repetitive. You fire anchor, push a space in, fire anchor, push a space in. So it takes about 2 hours to do, to maybe 2.5 hours. It's been pretty safe so far in the ones we've done. And I think the only way we learn about, is this going to help patients is by doing a randomized study, which is what we're doing now. But I think for most of us, what we've been impressed with has been the reduction in volumes on echo and in CT in some cases.
What is there a question? How do you know how much to cinch it? Is it a feel or is this calculated?
It's actually a great question. It's actually calculated. They've calculated on the bench. But when we deploy it, I don't know if you saw it was very quick, but there's a gap between each of these spaces and anchors. And it's literally like this cable comes out and attaches it to what looks like a fishing rod. Right? You put it in and you kind of reel it in and you tighten until all the spaces disappear. Space disappears between the spaces and you literally see it happening in front of you. And then when you cut it, it releases a little bit, just in the P2 region, because the last thing you want to do, because when they first developed this device, they just tightened it as much as possible. This was sort of 8-10 years ago, and left it super tight. And you can actually cause diastolic dysfunction by doing that, because you actually restrict relaxation of the ventricle. So now it tightens, and then as you cut it, it gives back a little slack. So that you can get you don't completely mess up with the diastology of the left ventricle.
Yeah, so that's right now. I think we know what not to do. We don't know what to do. Whether there's a specific cinch that's perfect for a given patient. And the beauty of this study is, from an academic perspective, we have 3D reconstruction and very tight measurements of all of this, and a follow-up CAT scan that shows us remodeling, that we're going to learn this from this trial. What's too little, what's too much? It will come out of this study first, I think. We have 113 patients randomized. I've been involved in many early studies, and many studies get stopped all of a sudden. Nobody knows why, but something happened. So usually something with the device that we didn't anticipate. I feel very good now that we have done, 113 randomized patients. Nothing's come up in terms of safety that maybe from 50 different centers before that were kind of unmonitored in 5 different studies kind of fell sometimes on the table. This is extremely tightly monitored, so I'm very comfortable with the safety.
Yeah. I think, the one question that I get sometimes when I present this data at conferences, when you're not there to back me up usually, is that in surgery, they've tried all sorts of things to reduce the left ventricle, all sorts of the Batista operation, we all remember that. There were tons of different surgeries that were tried to reduce LV dimensions, and none of them were successful. And why not? I think part of the problem is in a lot of those patients, when you take a patient with a 25% EF and you put them through major surgery like that, we forget the negative impact of being on a heart-lung machine and of being on a pump. And probably that had a negative impact on a lot of these patients. So the fact that we do this beating heart and it's a general anesthesia, not that deep, is probably also playing some impact in the recovery.
Yeah, any questions from anybody here? I don't think there's anything on the chat. Are we ready to move to Dr. Murthy's talk?
Yeah, we're having a couple slide issues.
Slide issues.
Yeah.
Okay, then maybe we just move to your talk first.
Sure. Yeah, I was just going to ask a question as I get up there for you guys. that how many, this trial definitely with the preliminary data that came out in JCF. I mean, I'll just be honest, this, that I wasn't really referring any of my patients for this until recently. After I saw that data, I was a little bit more convinced. I was hesitant. Yeah. How often do you see, and maybe Azim, you've done a lot of these early trials, do you see something like this start out and look positive? And how many get to this point where you start getting preliminary positive data?
So, I've done lots of, as first in man studies and early studies, but the thing I've got to say about this company that I'm appreciative of is this is one of the few times we've gotten so far in a randomized trial, right? And in the randomized trial, we have a whole lot of different endpoints or parts where some of the data will be analyzed. There's a DSMB that looks at on a routine basis every sort of 6 months. It looks at the events and will stop it if there's an issue with the study with safety. And so far, we're going pretty strong because there've been no issues. So I think the fact that we've gotten to a randomized study is very important because a lot of these other devices don't get that far. The one thing you could argue, which usually the heart failure doctors argue with me, is should we have done a sham control study? Okay, it's just hard to justify putting a patient through general anesthesia, a 20 French sheath into his femoral artery, keeping them there for like an hour under general anesthesia and then pulling everything out. It's just hard to judge because there's risks of putting a 20 French sheath into a patient, right? So that's the problem with kind of doing a sham control study.
Yeah, I agreed. And again, here, the beauty of this study is the imaging part later. This is going to be very convincing, I think, what we see on 3D reconstruction of CAT scans with contrast after a year.
But I also think, the other thing is people often ask me, how common are these patients compared to the mitral clip patients or the HDH repair patients? So, there's some data from Greg Stone and so on when they looked at COAPT, patients who perfectly meet the COAPT criteria for FMR and heart failure patients who meet the COAPT criteria, who have severe FMR on GDMT still symptomatic, who it's probably 7%, 8%, somewhere around there, maybe 10%. There's a lot more patients like this than there are patients with severe FMR.
Yeah, an important practical point is that this patients are eligible for this therapy 3 months after mitral clip. If the mitral clip is done, the MR is successfully treated, and they're still symptomatic, they would be eligible if they meet all the other criteria to be in this study. And how many patients exist? I just showed you a graph that treated mitral clip patients, that 75% of them are going to be dead after 5 years. So I'm going to say that,
and
at least 75% must have some symptoms before they die, right? So that's something where you have cured that, they basically cured that lesion, and they're better, but they're still not good. And from a patient primary cardiologist perspective, like me, where we have our patients for years, I'm much more comfortable to send somebody that, for example, had a mitral clip and is still not better. And I see that things don't go right. That is already instrumented, has the experience, is willing to undergo something like that. That's something that, if you look at your practice, something to think about, especially if they are not 85, right? And you don't want to subject them to another procedure. But if you have a patient between, 65 and 75 that says, yeah, I'm better, but something to think about.
So I'm a very much a cup half full person, or half, rather than half empty, especially for mitral clip. It was 92% 5-year mortality if you're untreated with severe FMR. At 5 years.
Yeah.
With an absolute reduction of almost 20% in mortality. That means if you treat 5 patients, we treat 5 patients with a mitral, we'll make 1 live longer and save their lives. That's pretty dramatic.
It's dramatic. There's no question about it.
Yeah.
The problem is that
I'm trying to make sure I get mitral clip referrals.
Okay. Very good. How's the AV situation coming along?
I didn't get the email.
Okay. So let's move to the, you have on the
We can move on to that. I'll turn it.
questions. Do we do the last talk now? Let's do that. let's do last. I mean, the way it was choreographed was medical therapy, investigation, and then, transplant guard. So Sneha Patel, who directs our transplant program, is gonna just give a brief overview of where we are with LVAD and heart transplant.
Thanks, everybody, for sticking like that. I'm going to switch gears a little bit from talking about earlier heart failure, about what to do when the heart completely fails. I don't have any disclosures. So just to start with a few statistics, some of this Yogita went over already. Her numbers were a little bit higher. 5.7 million people in the United States have heart failure, but importantly, about 1.5 million are in the advanced stages. And they compromise most of the almost 270,000 deaths per year from heart failure. So these are really huge numbers. And when we try to think about how we're going to prevent those 270,000 deaths, we realize that almost 25,000 of these patients, when you look at the right age category, not having comorbidities, would be a candidate for advanced heart failure therapies. And I use the term advanced heart failure therapies because it's not just heart transplant. It's also left ventricular assist device. And this brings us to the point that right now, because of donor shortage, we do about 4,000 heart transplants per year. So there's that gap where LVAD and other therapies are coming into play. So just to really hammer home that point, I think that this is a really sobering slide. When you look at class 4 heart failure, the 1-year mortality is really terrible. It's similar to having aggressive lung or pancreatic cancer. And this is where we can really move the needle in terms of mortality for heart failure. So who should get a transplant or LVAD? Who should get advanced therapies? I think that this patient who, if you walk into our cardiothoracic ICU or CCU any day, you're going to see, and this is really obvious, this patient is on ECMO, right? So they have complete circulatory collapse and are supported by this external pump that supports both the cardiac and pulmonary circulation, obviously on a lot of drips and intubated. And certainly this patient, if we can get him to the right point, should go on for advanced therapies. But I want to tell you is that we don't want to wait till this point, right? If you look at the data, when we take these patients with really severe cardiogenic shock, they do worse after LVAD transplants. A lot of times they get that sick and we have to say we can't offer it to them. And the data bears this out. If we look at post-transplant outcomes, a little bit earlier, but I think this probably still holds true at patients going to transplant from ECMO, you're going to see that the 1-year mortality is almost 50%. And that's a dismal outcome. We wouldn't transplant somebody that has a 1-year mortality of 50%. And it's the same thing with LVAD. A lot of times going into LVAD, we use something called intermax class without going into it. The lower the intermax class, meaning 2, 3, 4, 5, 6, 7, is less sick. Intermax class 1 generally is ECMO patients. If you look at 30-day survival, it's actually not so good in intermax class 1. So generally when patients get that sick that they end up on ECMO or need balloon pump or temporary support, we don't want to wait till that point. So the main thing is that we want to get patients at the right time for heart replacement therapy, just conceptually shown here. We're on the x-axis, you have the clinical severity of heart failure getting worse, and the y-axis, the operative risk, the risk of the procedure. And where we want to be is not where it's too early because it doesn't justify the procedure. And we don't want to wait till it's too late where their comorbidities make them not candidates. So we want to really get in that perfect window. The question is, what is that perfect window? And a lot of that is kind of the art and science of what we're trying to pick out. And it's really actually a tough thing to do sometimes, to be sitting and talking to a patient who's not hospitalized, who's not an extremist, and say that I think that you should go for LVAD or transplant. But I think it is, in the right circumstances, the appropriate approach to prevent a future mortality. So who should we be thinking about for referral for advanced therapies for transplants? This is an acronym that we use quite a bit. It's I need help. We actually have cards for this that I forgot to bring today, but I'm happy to share them. I is IV inotropes. N is New York Heart Association class 3B or 4. E is end organ dysfunction. E, the second E is ejection fraction. D is defibrillator shocks. Hospitalizations obviously are a huge predictor. Edema, low blood pressure, and then probably the last one is really the most important one, and the one that we see in clinic the most, which is they cannot tolerate guideline-directed medical therapy, or you have to cut it back because of AKI or hypotension. So let's say you have one of these patients and they're referred to us for heart transplant LVAD evaluation. What are we going to do next? We want to do our best to confirm that this is a patient that really should proceed, and we're trying to look at objective assessments. And the two things that we look at are, one, hemodynamics. So almost everybody's going to end up getting a right heart cath. What ends up being the most predictive is what their filling pressures are, in particular on the left side, the pulmonary capillary blood pressure. And the second thing that we're going to look at is peak oxygen consumption via cardiopulmonary exercise testing. So this will measure their functional capacity. In a person with the normal peripheral muscle oxygen extraction in normal lungs, you assume their limitation to utilizing oxygenation is the heart. And this is a really classic study in the heart failure field, almost 30 years old, from Donna Mancini, that looks at mortality based on peak VO2. And if you see a peak VO2 of less than 10 has more than 50% mortality at 1 year. And this has been reproduced in current era on current meds and different demographics over and over again. So this is one of our really big prognostic tools that we're going to use. So let's say somebody goes through the whole process. We think that they medically need a transplant. What's going to hold them back? Some of the things that we think about are basically broken down into anything that's going to affect their chance of living 5 years otherwise. Because when we're talking about transplant in particular, that's a limited resource. If we give it to somebody that dies in a year, there's somebody else that could have lived 11 years that didn't get that heart. And we're trying to do our best job to adjudicate that. Obviously, age plays a role. We certainly try to look at physiological age more than chronological. We've gone up to 73, 74 for transplant. Certainly somebody that has malignancy, unless it's in remission for more than 5 years, we're not going to do. Anybody with end-stage liver, kidney, or lung disease otherwise would not be a candidate. And then we also have to look at the psychosocial part of this, because post-transplant care is burdensome. There's a lot of medications, a lot of follow-up, and if there's somebody that can't comply with a very complex regimen, they're probably not a candidate. And then the last thing that's really important is frailty. There's no one particular way to capture this, but you may send us a patient and certainly they're going to die from heart failure, but because of the frailty, they're not going to be a candidate. And we look at their functional status, we look a lot at hand grip strength, what their nutritional reserves are, have they lost weight. But if somebody doesn't have contraindications, they're a good candidate. We have a multidisciplinary heart transplant selection committee. It's mandated by CMS. We meet every week. And it's not just the cardiologists, it's the surgeons, nutritionists, social worker, pre and post transplant coordinators. We all get together and really try to make the best decision that is this somebody that's going to benefit from a scarce resource such as transplant. And one thing that I like about this is I think that I see it expanding to a lot of different areas of medicine, certainly in cardiology with heart team meetings and both structural, interventional, and EP. When we do transplant, the outcomes are incredible. So this is data going back over 30 years with over 100,000 transplant patients. And you can see that the median survival, the 50% portion, crosses the curve at about 11 years. And so if you think about taking patients that have weeks or months to live and offering them 11-year survival, there's not many things in medicine that we do that has this sort of impact. And it's not just survival, it's quality of life. This is one way to look at quality of life, looking at functional limitation. Red is none, yellow is some, green is they're completely limited. And if you look at heart transplant survivors at 1, 3, and 5 years, what you'll see is that almost 90% have no activity limitation during these time periods. So a great therapy both for quantity and quality of life. But as I stated beforehand, we don't have enough donors. The donor supply is going up. Two big things that have changed is over the last 5 years, as you see the steep part of the curve, is that we're starting to utilize organs we never used before. Those are donors that have hepatitis C and donation after circulatory death. One of the things that I'm most proud of is that this is something that we've contributed to as an institution quite a bit. We've had papers in JACC, in Journal of Heart and Lung Transplantation on Hep C and on DCD and JACC that our whole group has contributed to and really has helped move this field forward. In the end, though, we're looking at a curve of almost, 4,000 transplants per year. I mentioned there's 25,000 plus patients per year that could benefit from therapy. And there's a need, and that need is filled by LVAD. And this is the evolution of LVAD therapy. The HeartMate 1 was a pulsatile pump. It was big and clunky. Because of the moving parts, it was prone to mechanical failure. The HeartMate 2, 2008, approved by the FDA, really changed the field. There's very few to no moving parts. It really impacted mortality. And the latest iteration, improvement in technology more than medicine, was the HeartMate 3 in 2017. This is considered full maglev technology. This is the pump right here. You can see that there is, I don't know if there's a pointer, but there is the pump is placed intrapericardially in the left ventricle. There's an outflow graft coming up to the aorta. And then right here is the drive line that exits the abdomen somewhere about here. And the externals are the system controller of the battery. So they do have to walk with these around. Those are externally from them. The result is, though, that they have excellent outcomes. This was a New Journal paper that Dr. Goldstein, our surgeon, and Dr. Yordi were both co-authors on. You could see just really incredible survival. When they compared it to the HeartMate 2, it was an improvement, 78% event-free survival. So that means survival without stroke or needing to replace or malfunctioning a pump. Remember, we're talking about patients with weeks to months to live. Once again, an incredible achievement. And then probably the most important thing that's come out recently was Intermax is what really regulates and is a registry of all LVADs in the country. And each year they put out an annual report. This past year, Dr. Yordi was the lead author on this and put together all of this data. If you look on the right, you can see the highlights there. So this is basically with the HeartMate 3 pump. We're talking about a 5-year survival of 64%. And this is a really incredible achievement. Once again, hasn't fully approached what transplant can do, but we're getting really close. You look at the younger population, less than 50, 92% 1-year survival, 5-year survival, 76%. And then you look at the age greater than 70, a population that we've generally been afraid to touch. If they're doing well, otherwise, this isn't a bad option for somebody that actually wants to live with almost a 50% 5-year survival. So, I'm keeping this relatively brief, and I'm going to spend the last couple of slides pointing out something about our program. So this is SRTR, and this is publicly available. So the transplant community is closely monitored, and it has to be publicly reported outcomes. And you can go in and select the organ and the state, and these are updated biannually. This, if you pick New York at the top and you look, and this list goes down further, there's about 7 programs in New York State. You can see that based on 3 categories, deceased donors, survival on the wait list, getting a transplant faster than 1-year heart survival, we're actually the #1 program in New York State, something that, considering our location, the complexity of our patient mix, we're very proud of, and takes a lot of effort. And when you look at the national, we end up number 6 with some of other very large programs like Vanderbilt and Mass General and UCSD. And I'm going to cut to my 15 minutes right there, and happy to take any questions.
Any questions in the room about any of this? Messaging, of course, what we want you to tell people who couldn't attend today is that we have the best transplant outcomes in New York, which is a big deal and something we're very proud of. And it changes every 6 months. So if you don't tell them now, it may be too late in July, okay? Also, what Snehal showed, an LVAD therapy. People just have the wrong impression of what this therapy can do in 2024. When you have a 64% survival of a population that remaining on medical therapy, the 2-year survival would be 0. And this is something that you have to communicate to the patients, before you may say, hey, there's this thing with the batteries, do you want that? And they say no. Often the bad news that should be delivered first. The building is burning, we're on the third floor. If you're just saying we're on the third floor, why go anywhere? But you have to say that the building is burning, and then the patient should make the choice, not us. They need to be informed. How are we doing with the AV situation? Oh, Sandhya, is it on the stick or somewhere?
2 more minutes.
Okay, so you can work on bringing that up, and we can, are there other questions on this? One question that often we get asked about the AccuSync trial, where you go inside the heart and put all these anchors. Does that prohibit LVAD in the future? The answer is no. Does it prohibit transplant in the future? The answer is no. It's really, tonight kind of the idea was to get together and give you a flavor for the spectrum of the treatment of heart failure. And the big message is that there are lots of things to do. And I would say that at minimum 30% of all comers reach the point of eligibility. They pass the point of eligibility, and then it's too late. So that's something where, we want to broadcast a message to everybody that's here, that sees patients, to think about these things, to think that other things can be done. And if the time doesn't permit, or, that's where, we like to jump into the gap and educate the patients. Great. Okay. Last presentation is Sandhya Murthy, who probably many of you know.
Your slides.
Huh?
Maybe we can just give them a
You wing it through
overview of the trial.
Yeah.
All right, so
You can just bring it. Sandhya is known for pulmonary hypertension. If you have pulmonary hypertension patients, she runs our center. She uses a lot of mavacamten. We don't have time for that today, but she's also the principal investigator on this study for HFpEF. So just wing your way through it.
Okay, so this is with the caveat, I apologize for all the AV issues here, but not my slides. But what I did want to do is provide a kind of overview on HFpEF options beyond the SGLT2 and the ARNIs and basically that's it. That's all we got. So that kind of opens up the door for transcatheter therapies for HFpEF. And so, the idea of a left atrial shunt, where did that come from? It's kind of crazy to think about it, but the hallmark of HFpEF is really, we alluded to this, of how do we define HFpEF? Is it just symptoms of heart failure in the midst of CKD, of obesity, diabetes? It's very difficult to tease out. But most trials now would agree that you have to have some structural evidence, like a large left atrium, you have to have LVH, you have to have BNP. But more importantly, you have to have the hemodynamics that confirm this. And this is one thing that we've learned doing these left atrial shunt trials, is that the hemodynamics at rest don't always convey the exercise limitations that these patients face. So we can have a wedge pressure of 15, yet the patients are telling you, I'm really short of breath walking across the room. It's the exercise hemodynamics that really clinches the diagnosis, I think, and this is something that we've been doing a lot of, and which is why this is a very kind of exciting thing, just to explore the hemodynamic limitations of HFpEF, which isn't always obvious. This looks promising. Maybe something's happening. Yeah, Paul?
Is this what the device looks like?
This is the device, yes.
We're gonna try
Okay, before I say too much.
the other part.
So that's kind of the background, in that, we've explored all the medical therapies that we have available, and now we're trying to think about the root cause of limitation in HFpEF, which is generally elevated left atrial pressure, not just at rest. Sometimes it's normal at rest. If you do all these catheterizations on starving patients at their driest state, you're going to get a normal wedge pressure, and that's not it. You have to do the exercise study, and you see these dramatic rises in wedge with exercise. So hopefully we'll have some slides to show you that point.
How do you exercise that in the cath lab?
Yeah, so
We'll
get there. We'll get there.
Sandhya, can you just remind me, what's the prevalence of HFpEF and how often, and what's the hospitalization or emergency room
and
rates?
I think Julia probably went through all of this in her slides. Yeah, but it's just as morbid and highly mortal, just like HFpEF. So we think of HFpEF as the more benign disease, but actually is increasing in prevalence, and probably the aging population has a lot to do with this. And it's equally high mortality, equally high morbidity with HFpEF hospitalization. In fact, it's more split like 50-50 at this point in the hospitals, and probably a lot more HFpEF these days now that we have a more aging population and people are living longer. We're going to start to see this a lot more. So just speaking about left atrial shunts, is anybody, just to think about, I love this historical stuff, but where it came from and where the idea came from. Anybody ever heard of Ludenbacher syndrome? Yeah, so I see a lot of nods here. But for those of you that aren't so familiar with this, Rene Ludenbacher was a cardiologist in the early 1900s, and he had a patient with rheumatic mitral stenosis, a 61-year-old woman who was actually also born with a primum ASD and congenital shunt plus a acquired mitral valve disease. And he hypothesized that the reason that she was 61 with tight mitral stenosis was that she had a somewhat of a pop-off valve and was able to do this left to right shunting. Oh, there we go. I got it on my screen.
Okay.
All right, we're in business. You don't have to listen to me talk. You can look at the pictures.
There you go.
Okay.
Excellent.
Okay. How do we address this?
There's the arrow.
Okay. So we start off every talk here with a short case. So this is a 72-year-old guy. He's coming in for an evaluation of dyspnea on exertion. You see that his blood pressure is fairly well controlled. He has hypertension, diabetes, paroxysmal AFib. Probably should think about ablation, but that's for another talk. He's on Entresto, Jardiance, and metoprolol, and is complaining of worsening dyspnea on exertion, fatigue after stairs, and 3 blocks. So here's his echocardiogram. The important points here that I want to show you is that there is some LVH, LV function with neurology is fairly normal. Left atrium is large. Right atrium looks okay. Right side looks okay. A little bit large, but for the most part, it seems like the LV function is preserved with a large left atrium, suggestive of diastolic dysfunction. So we talked about this a little bit, but what is HFpEF? It's symptoms of dyspnea and exercise intolerance. And I highlighted that because that's really the focus of this. In addition to that, you got to have something that goes for it, like a large left atrium, LVH, congestion, and normal LV function. So this is the hemodynamic definition that I alluded to. You have a wedge at rest greater than 15 or an exercise wedge greater than 25. Again, Dr. Shin has gone over this in detail, but we don't have a lot. We really just have SGLT2s and neprilysin inhibitors, and perhaps aldosterone antagonists, if you believe the TopCat trial. But we don't have many options. So that left the door open here for transcatheter therapies. And we're going to talk about this guy. This is the case of, this is a echo picture of Ludenbacher syndrome, where you have this ASD plus rheumatic or some tight mitral valve. And the idea that you can decompress that high left atrial pressure with creating this hole through the atrium. This brought a lot of pictures, though. This brought a lot of questions, rather, in the sense that obviously, rheumatic mitral stenosis, large ASD, these patients will get progressive pulmonary hypertension, Eisenmengers. It's not good in the long run. So what is the optimal size of the shunt? What is the optimal timing of the shunt? How do we decompress the left atrium? And what phenotypes of heart failure benefit the most? So we've had about 115 years or so to think about these questions. And this is what we got. This is a crowded room of left atrial shunt therapies. So the first 3, the Corvia, V-Wave, Aquatech device, these are actually implanted shunts through various stent mechanisms and direct left atrial to right atrial punctures with various sizes, as you can see. These last 3 are creating a hole, essentially, using either a coring catheter, RF catheter, or cutting catheter. So again, the same idea of creating a direct left atrium to right atrium shunt. The Edwards implant is a novel mechanism of creating a shunt, not from LA to RA. We avoid the interatrial septum, but through the left atrium and the coronary sinus. So we'll talk in a little bit, and I'd love to hear Dr. Latif's ideas on all of these different mechanisms to create this left to right shunt, but we'll talk about why this makes the most sense to us as a program and why we would like to spend a little bit more time talking about the left atrium to coronary sinus shunting. So just going to the first type of device, which is basically an implanted shunt in the left atrium, we have the Corvia device, which is the largest trial done to date, 626 patients with a sham control, and it was randomized. And the inclusion criteria broadly were an EF of over 40% with exercise hemodynamics. So this was nice. We have a lot of exercise data, and to show that the wedge pressure goes up to 25 with exercise. Unfortunately, there was really no benefit with this device versus control arm. And in fact, there was an early signal for more major adverse cardiovascular and cerebral events in the intervention group. Now, if you think about it, we're creating a direct left to right atrial shunt. We have the potential for infection, embolism, device embolism, and then you basically can't get another transeptal intervention, whether it be AF ablation or even a mitral clip. Those days are over if you have one of these things in your intra-atrial septum. So for those reasons, this hasn't really been abandoned. I should say that there's a lot of sub-studies going on to try to hone in on what population may have had a benefit. And what's starting to come out is that there is a subset that has fixed pulmonary vascular disease that was underrecognized that perhaps wouldn't have benefited from this. And maybe there is a role in a certain subset, which if we define the hemodynamics properly, we can find that subset. Now with the direct, creation of a hole between the intra-atrial septum without placing an implanted device, we have RF ablation catheter, but the early experiences, this has been largely abandoned because of the shunt patency. They found that after 6 months, the shunt size were half the size of what they started with, probably due to pans formation and just, direct trauma to the intra-atrial septum. There's coring catheters now that they're looking at, which show promise, and we have some ongoing trials looking at that. But the same concerns exist as if with the actual implanted shunt, that you're creating a connection, you have embolism risk, you have infection risk, etc. So we'll come to our novel shunting approach, which is the left atrial and coronary sinus. So I'll show you a video on how it's done, and Dr. Latif can walk us through it. But in essence, what we do is we preserve the intra-atrial septum this way. There's a lot of benefit to doing that. Number one, we don't have to worry about paradoxical emboli. Number two, there's a kind of a burgeoning field about RA flow dynamics. Just like we talked about LA myopathy, there's probably a RA myopathy too that you create by interrupting the normal flow of blood through the right atrium. So that's a lot of interesting data that's coming out right now. So the ALT-FLOW 1 was the first early feasibility trial done, and it's complete with 87 patients. And we were a center in this trial, and basically we looked at rigorous exercise studies in these patients to try to understand, one, who would benefit from this. It has to be a patient that has elevated wedge pressures with exercise to appropriate rise in wedge pressures. And what we found is that these patients, after having this implant placed, and this was a open label, meaning that there was no sham arm, there was an improvement in KCCQ, 23 points, reduction in exercise wedge pressure as predicted, about 7 millimeters of mercury. So that trial, it gave us a lot of good information on the safety of doing this approach, as well as the hemodynamic benefit that we can expect. So back to our patient, we have, we thought about maybe this would be an appropriate patient for this left atrial coronary sinus shunt procedure, and we wanted to get the data. So we brought him to the cath lab. We have our baseline measurements here. Right atrium of 3, pulmonary pressure is 29, 17, 21, and a wedge of 9. So again, this is a guy with a large left atrium that has so-called diastolic heart failure, yet he has a wedge of 9. But now I wanted to give you a picture of our bike here. This is what the patients see. It's a supine bike that we kind of wheel into the cath lab and place it, directly under their feet. So they're lying on their backs and they're pedaling. And we have a protocol where we increase the load. It's a very nice bike. And with peak exercise, with our protocol, we see a rise in right atrial pressure minimally to 8. The mean pulmonary pressure goes up to 46, which is severe pulmonary hypertension. And now we have a wedge of 32 from 9 with a V wave of 44. This is very dramatic. So this is as obvious as diastolic heart failure as it gets, that you have this dramatic rise in wedge pressure with a V wave with a symptom-limited bike exercise. So I don't know, Dr. Latif, you want to talk through this procedure?
Yeah.
Can we put the volume down? I'm not sure if the volume is going to be up, but.
So, yeah, another unique procedure we do in the cath lab. We've been doing this under general anesthesia. You could probably do it under sedation, but we get right internal jugular access. There's about, I think the sheet's about 24 French we put down into the right atrium. We cannulate the coronary sinus and then take an angiogram of the coronary sinus so we can identify the spot where we want to create the shunt. So this is us going down. Sounds like a big sheath, but for internal jugular veins, it's actually not that bad. So this is a wire that goes in to let us bring a catheter. We have a special catheter with a balloon tip here that pushes us to the wall, and we literally then, through this catheter, make a hole with the needle into the left atrium, put a wire. Over that wire, we then go with a balloon and balloon a hole, basically make a hole between the left atrium and the coronary sinus. And then to keep the hole patent, we then deliver the stent that sits in the left atrium and in the coronary sinus. There's 2 parts that clip onto the left atrium side and 2 arms that clip into the coronary sinus side to maintain the patency. The procedure last one we did took about 40 minutes, 30 to 40 minutes to do. It's actually not a complex procedure to do. Very kind of straightforward because the catheter and system that have been designed to do it are pretty straightforward. And maybe when you finish, we'll talk about the differences between this and an intra-atrial shunt.
Sure, yeah, okay. So just going back to our patients quickly, I'll wrap it up, but we see that the 3-month baseline hemodynamics now after the shunt placement is wedge pressure is 13, mean PA is 21 at baseline. With exercise, although it's not perfect, and again, this is where the fine tuning will come in with shunt size, duration, and things like that. We see that the wedge pressure went down is what we saw in the trials, just about, 7. The 7 was in the trial, we saw a decrease of 8. But the difference is there's no V wave here, which is, I think, is very interesting that we don't see that elevated V wave that we see with diastolic heart failure. So this is just one example case. And this is actually quite visible on echocardiogram. This is how we ensure that the direction of the shunt is the right way, meaning left to right, left to coronary sinus, I should say. So this is kind of an off-axis, short-axis view, where we see the coronary sinus running posterior to the left atrium. That's a close-up view of it. And we put Doppler through this, and we see that there's unidirectional flow through that from left atrium to coronary sinus. So again, lots of exciting things in the world of HFpEF because our medicines are just so far lackluster, for a better word, save for SGLT2. But we're still looking for what is the ideal heart failure phenotype. Certainly not everybody with diastolic heart failure. And should we be looking at these exercise hemodynamics a little closely? There's certainly a population that has lived with wedge pressures for so long that their pulmonary vascular system is not normal. So how can we expect that placing a shunt in these patients would actually improve their exercise hemodynamics? So there's actually a lot that we still need to do here. And then the ideal trial design should include a sham arm because there is that strong placebo effect. And when you're looking at things like KCCQ, which placebo effect, has been 15 points higher at least, we should really have a sham arm. And then the long-term effects of shunt creation, you're having chronic left to right flow. What happens to the RV? What happens to the right side, 10 years from now? So we need more long-term data. And this is where we come in with our trial now is the ALT-FLOW 2 trial, where we're looking at the left atrial coronary sinus shunt system in a more rigorous way, including not just the exercise hemodynamics, but we're actually going to have a sham procedure where patients will be randomized to either getting the shunt procedure or the sham procedure. And that way we can kind of take that placebo effect out of the equation. additionally, the endpoints are harder. We're looking at MACCRE at 30 days, as well as changing wedge pressure. So this is very exciting for us. We have 100 planned patients. We just are opened up for enrollment. So we're looking for the right person, and hopefully we can learn more about, if unloading of the left atrium is a viable option to treat HFpEF, which seems like thus far we don't really have much success in this field.
Any questions?
I've had this observation that when patients get Watchman devices, they come back and tell me that they feel so much better. And I say, well, actually, we didn't do anything about your AFib. I don't understand why you feel better. I think it's placebo. But, we also leave behind a 15 French hole in the intraatrial septum when we do the Watchman.
Right.
And I wonder if, and oftentimes it's sealed up by the time they get their 45-day follow-up TE, but oftentimes it's not. And I tell them, well, sometimes you have a residual ASD that's going to be of no clinical significance. But I wonder if there's if the iatrogenic ASD in some patients is actually therapeutic. The other question I have is, how much shunt fraction do you think you need in order to get a hemodynamic benefit, like in terms of QPQS or left atrial stroke volume?
I don't know about QPQS, but shunt size for sure has been looked at as far as simultaneous RA and LA pressures, and at what shunt size is the optimal flow where you don't have an inappropriate rise in RA pressure, yet you decompress the LA, and it's somewhere between 6 to 10 millimeters of a shunt size that has been shown to be the optimal. And this is, preclinical studies, but, the QPQS, I'm not sure that that's been looked at. But I can tell you that from at least our study in the All-Flow 1, there was no significant, shunting to the right atrium. And we measured, with our hemodynamics, we would measure the shunt fraction every single time with IVC, SVC sats, and do a complete oximetry run.
Maybe if I'll make a comment about the iatrogenic ASD. So I think your observation's right. We've been observing this for years in mitral clip, because in mitral clip, we leave a 25 French hole in the atrial septum. And we've always thought that maybe some of the benefit in some patients with mitral clip could be the fact that we leave them with a residual ASD. And so they can have a pop-off valve, basically, even if they redevelop residual or new MR. So I think there's some truth to that.
Yeah, I hate to disappoint both of you. The ones that leave the shunt behind, because the evidence that we have right now is that the hole in the intraatrial septum does not work. That's the large randomized clinical trial. The shunt in the, the shunt, they were a large study, 650 patients.
So it doesn't work in HFpEF patients without mitral regurgitation.
Fair.
Okay.
Fair enough.
It's a very different patient cohort.
Okay.
One of the things I think you've taught us all tonight is that there are all these very specific patient cohorts. And part of, I think, our problem with some of these therapies, like shunt therapies, is we try to use it in almost an all-comer population. And so some of the clinical studies they did initially, they just took patients with HFpEF, any patient with HFpEF, and they put a shunt into them. They didn't do even exercise hemodynamics. And as we've now, in one of these studies, learned, is that when you do exercise hemodynamics, that maybe there's subgroups of patients that may benefit. And that even in HFpEF, there are different subgroups of patients. And we need to find, as in with all therapies, who is the group of patients where it's going to be most impactful.
I think we work together too much. We're getting to know too much. No, but I completely agree. It's a very different phenotype. I have never really believed, at Montefiore, we have never enrolled a patient in the intraatrial shunt studies because we never believed in that concept, really. We were very, keen or bullish on the coronary sinus shunt. Because of the perceived safety, superior safety, but not being in the intraceptum, have paroxysmal embolism and all of that. And B, because the drainage into the coronary sinus and then better flow into the eye just seem more attractive. There are actually some data coming out that are unpublished from this device that in a longer term follow-up, the right ventricle looks the same. It's not loaded and stressed over time with the coronary sinus shunt. I think what's going to happen is we have a few more interatrial shunt studies coming out. I'm not sure they're going to be positive. Quite frankly, I don't think so. I think the explanations that we hear about pulmonary vascular resistance just don't pan out. We don't see that issue with the coronary sinus shunt. I think it's the shunt size, probably just like the cinching size, eventually a big problem, but the proof of concept, the shunts should just work on most of them. And the intraatrial right now don't. Coronary sinus, I think, looks more promising. And we'll see, what we can do with that study. And we have 2 patients already that we're going to start next week. Any questions?
Kind of getting a little bit off topic, but I'm just thinking, in the atrial shunt studies, it's been pretty clear that there's more systemic embolization, right?
I'm not sure it's that clear,
Okay.
but there's definitely, it seems in one of the studies, more adverse events in the patients who had the shunt.
Yeah. And I'm just thinking about what you were saying, Dan, with Watchman, right? The purpose of the Watchman is to prevent strokes. And if you're leaving that small iatrogenic ASD, I wonder if that works against the Watchman.
So maybe I'll just come,
It's a 15-French hole, the one with the Watchman, and it closes pretty quickly. So, we've been doing mitral clip and edge to edge now for 20 years. Actually, last year was the 20th anniversary since the first mitral clip was done. And so we've learned a bit of data, and I've been surprised about the fact that we've not seen more paradoxical embolism after mitral clip, right? It could be because those of us who do the procedure, at the end of the procedure, when we pull back our catheter and we see anything going right to left, we panic and we just close the ASD. And we won't leave a patient with an ASD. We'll only leave it if we see really good flow from left to right. That may be why, but just today we were in the car and one of our referrers called us about a patient. We did a mitral clip on 3 months ago who today had what sounds like a neurological event, right, with a residual ASD. So we can look at it. It's maybe the first one I found after Chair who had a paradoxical embolism. It's just not been that common. But again, it depends on the patient group, right? My patients with mitral regurgitation, they have high left atrial pressure, so that probably keeps the flow left to right.
I don't think we have data about just decompressing acutely. I mean, like, assuming they all close, okay? Just the decompression that you give with a hole that close after 90 days, let's say that, is just the decompression enough to improve the outcome of the patient or not? What do you think? That might be in some population.
So it's interesting. In some of the studies where the device has closed in 3 months, you've seen an improvement in KCCQ, and then you see the decline again when the device is closed. So, I do think there may be some parts we don't understand about long-term patency, and also about whether you shunt into a right atrium versus whether you shunt into a vein, and what role venous capacitance has, what role atrial diastology has in all of this. We still don't understand that.
Great. I want to close on time. Thank everybody for coming. I think we gave a pretty good overview over heart failure. Just take home message, the benefit of diastology, remember the patient that is an LVAD candidate has a 1-year mortality of 80% versus 5% with an LVAD. And I think the takeaway also is great interdisciplinary work, not just between disciplines, but also specifically with Dan here. We were really forming a wonderful collaborative team, and I think together we will continue to make important contributions to the field. So thanks for coming. The bar is still open, and those on the internet, thank you for participating, and Millie,